All right, the Yellowstone City County Board of Health will come to order. Besides Chris, do we have any guests here in the room with us or online who would like to address the board?
Mr. Chairman, I was just going to say I brought White as a guest so he could see, he could get integrated into what goes on here.
Excellent thought, Martin. Thank you very much. Any other guests that would like to address the board? Chris, can you introduce yourself for us?
Good morning. I'm Chris White. I'm the new county commissioner. I took John Austin's spot. I'm at about 4 months now, so I'm learning lots. I've been super and asked about 1 million-ish questions daily for me. So excited to be here and learn what this is all about. Thank you for having me.
Let's go around the table and at least share our names and our backgrounds with Chris. Spencer, starting with you.
Spencer Anderson, officer at Yellowstone Bay. I currently serve as the board secretary treasury.
John Doerr, past chair of the board.
Cheryl Lee, I'm on the board of health and I represent the RiverStone Foundation.
Michael Dennis, retired educator, scientist, and now fly fisherman. And winemaker. Life is good.
It's a long talk. It does not sound like you're retired.
Anything else? No. That's not for now. Or like.
Carrie Ludwig, and I'm deputy assistant.
Jim Harris, board chair, former finance guy.
Good morning.
Cromwell lawyer.
Reinhold Tapia, retired pediatrician, and I'm appointed from the clinic board for this.
Aaron Lambert, and I'm the CEO of WCA Billings, and also
Morning, I'm Debbie Davis and I'm the school nurse of the school system.
Thank you. First order of business is approval of the consent agenda for the meeting minutes, excuse me.
So moved.
Second. Any changes or modifications? Hearing none, all in favor, aye.
Aye.
Opposed, same sign. It passes. John, your report, please.
All right, good morning, all. Report is in the packet, and first order of business is a hot topic that's not the Behavioral Health Center, but the Colonial. I think would be the antithesis of the Behavioral Health Center. You know, we talked to Q2 last week. I had the opportunity to talk to, what's the other one? Where's Casey? Color 8 last night. Ran the story again, talking about our efforts to relocate folks. Working with the COC, the Continuum of Care, we were able to get at least 12 residents into either new housing, substance use treatment, addiction med, or behavioral health facility recently. And so that work continues. We have a couple additional residents that will be displaced over the next couple weeks. And we have 2 of those, I believe, lined up with the COC with new housing opportunities. COC and other agencies were able to help pay application fees, pay deposits, and help folks get rehoused who were eligible to be rehoused. COC, the Continuum of Care, the group of 16 entities for housing services. Yep. So we continue to make outreach visits via the homeless outreach team, as well as the sheriff's department, working to notify everybody about their pending evictions and the process that's going to take place. So we're going to, as soon as the building is empty, work with the owners to secure it. They are under, the estate is under court order to secure the building, make sure that no additional residents can find their way in there. We've engaged a contractor for asbestos abatement, for fencing, for security, to help them with that process. And then as soon as it's empty, the abatement contractor is ready to go in there, tear out some of the friable asbestos material, and then begin the demolition. So all of that should be taking place at the start of the new year, if not sooner.
Are the two homes, two
And the
houses,
two houses.
two homes, are they
All
empty?
included.
They're all, oh, I know they're all included.
Yeah.
They're empty now.
The one home is not. So they're working on that too.
Can they, can they secure the other one so people don't get into the other one?
They're trying to do all of that. Yeah. It's process. I'll be meeting with Chris Kukulski later today to talk about the city's pending litigation on the property and figure out how we work through settlement with the estate and clear our purchase so that we can take clean title of the property and then take care of the problem. So more on that. Gosh, we had an incident a couple weeks ago. My kid's school, actually, St. Francis, they had a local student had an unknown allergy, food allergy, and had an anaphylactic reaction. And the school nurse didn't have a stock of additional EpiPens, as is the case in many schools across our region. And so school nurse fortunate enough to call another parent she knew, use that child's EpiPen, and take care of the child's allergy. But it just brought to mind something for me to work with our public health department folks and create a list of must-have. And that includes EpiPens, AEDs, Narcan, and Stop the Bleed kits. And so we're going to be working with our local schools to make sure that every school across Yellowstone County has those 4 things in all of our schools in the event of an emergency. We were able to write a standing order for the school nurse to have those EpiPens, and there's a free program where schools can access once they have a standing order to those EpiPens. So Debbie, happy to work with you and SD2 to make sure that all your schools have them.
Yeah, they are pretty much. They also do everything training with our staff members so that they know how to get it in. That they just want to develop.
Great.
They were covered.
Good.
And one of the 4 things you say they needed was quick clot or?
Stop the bleed.
Yeah,
Yes.
stop.
Yeah.
Okay.
Yep. Recently, when SNAP and WIC benefits were brought into question, got a call from Billings Clinic Foundation and Billings Clinic leadership, and they asked how they could help our clients. And so they did a food and diaper drive, baby food and formula drive, and with their leadership team, and brought all of that down to our family health services team recently, so that we can continue supporting those folks that we serve, even in questionable federal funding states. We reconvened SNAP as of November 15th, and so benefits were paid out. And so there's no further issues at this moment in time with SNAP benefits. I think I've told some of you my story before, but it's been 25 years, and I cannot believe it, since I lost a friend in the middle of a high school basketball game due to sudden cardiac arrest. He dropped dead at halftime in the locker room at one of our rural schools where I grew up in Pennsylvania. And it took 45 minutes for EMS to get there. There was no AED on site. And the doc said, if he had access to an AED, he might still be with us. So 25 years ago, that triggered my Eagle Scout project and worked with Greg's mother to make sure that public access to AEDs was a priority. And we got to put them in schools across Monroe County, Pennsylvania. And we actually had one shortly after it was placed, save a faculty member's life. Last month, we were able to donate an AED from RiverStone Health, and for me personally, in Greg's memory, to Lockwood Little League and make sure that they have one at the Little League fields, because there should not be a sport being played, particularly a youth sport, without an AED on site. So we're going to try to figure out how we sustain that. And it might even be something I go to the foundation board and ask for us to raise some funds so that we can keep getting AEDs out there across the community.
What's the approximate cost of it?
Between 15 to 35, depending on the model. Some models more expensive are universal, and they come with universal pads and a child mode, so that depending, doesn't matter who goes down, you can still use that AED. Other AEDs have child-specific pads and other things that are harder to use. Good news on the family health services front and our Kid Connect program. The check finally came in from Cushing Terrell's golf tournament, and we got $24,181 for our Kid Connect services. So Steve and I's golf day paid off, even though we didn't golf very well.
We would have gotten more money if we had.
We have narrowed down our search for chief people officer and made an offer this week. And so we're waiting to see what happens with our top candidate, but hopefully they'll accept and we'll be able to move forward with filling that HR role.
Are they local or from outside?
In-state.
Inside.
In-state. Yep. We have successfully rolled out same-day scheduling online, as well as online scheduling for immunes or rural clinics and other sites. And so again, just trying to be more patient-centric and create more access to care. Folks can go on our website and schedule some appointments. We also have a two-way chat bot on the website now for scheduling, talking to our front desk staff about your appointments, trying to make it easier for folks to come see us. Last month, Melissa Henderson, our public health director, we traveled to Helena to talk Kratom with the Economic Affairs Interim Committee. And we were able to provide some education on emerging intoxicating substances, say that 10 times fast. But our primary focus is on the sale and consumption of kratom and highly concentrated kratom derivatives. And so on Monday, with the Blessing Policy Committee and numerous discussions with this board, as well as the local governing authority, will be moving forward with notifying licensed food establishments that they can no longer sell kratom or kratom-containing beverages, food items, etc., because it is not recognized as safe by the FDA or USDA, and therefore it cannot be in a food item in a retail food establishment. So there will still be areas for the stuff to be sold, whether they're smoke shops or gas stations and marts without food service. But this is our way within our regulatory authority to make sure we keep a dangerous substance off the streets. And then tomorrow, I'll be testifying at the Board of Pharmacy, talking about the dangers of kratom and 7-OH and other kratom derivatives, with the hope that the Montana Board of Pharmacy will vote to add kratom and synthetic derivatives to the emergency schedule, therefore outlawing them and classifying them as a Schedule I narcotic in the state. They can do so for 120 days until we get to the next legislative session. So more to come after Friday's meeting with the Board of Pharmacy.
Can you, because I know that you mentioned me today, great. Can Greg help out with that at all? Does he have any use in that arena?
We've worked with the administration, we've talked to the AG's office. There's a lot of folks working on the issue at the state level across different agencies, whether it's Department of Revenue or DPHHS, and we're all pretty much in alignment. Okay, so it should go forward. Also had a good meeting last month with the Montana Rescue Mission and their board of directors. Was able to talk to them about our new healthcare for the homeless clinic that will be stationed at the mission, as well as address the Billings Chamber of Commerce Board about the behavioral health facility and other healthcare issues across our community. The staff had a good chance to celebrate Halloween, so I wanted to include those photos for you. Question was asked last month about employee turnover. Employee turnover for November was all the way down to about 0.8%. That's down from a 2025 high month over month to 2.36 back in July. And our cumulative turnover so far for the year is about 14%. Just for perspective, nationally, reports of turnover in healthcare range about 18 to 20%. So we're still running below average, which is what we want to see. But the highest turnover so far across the country is in nursing, about 24%, and in licensed technical roles, medical assistants, lab techs, et cetera, about 18%. So,
And are they just chasing the dollars?
they're moving around organizationally, but there's also this, for perceived burnout or quality of life, chasing other careers too. And so that's kind of generational. The youngest generation is leaving healthcare more quickly, about almost 40% turnover, followed by millennials, 22%, and then Gen X and the boomers, 14 and 19%. They're sticking around more. But I wanted to throw that in there since it was asked last month. And then we officially launched our loss team in November. And our loss team is called Local Outreach to Suicide Survivors. There's about 100 of these teams across the country. And our health department is collaborating with volunteer therapists, behavioral health providers out in the community, as well as here at RiverStone Health in our clinic. And these volunteers will respond shortly after suicide. We get confirmation from county coroner, and we're able to provide outreach and services to families of the victim, loved ones, friends, and provide some intervention so that we can stop, hopefully, an epidemic from happening. But that's a positive development. And then on the public health front, you may have seen in the news, Gallatin County reported their 21st case of measles last week or earlier this week. Put up a bunch of exposure sites there. It's a busy Thanksgiving weekend. And so the grocery store, Costco, the mall on Black Friday were several exposure points for measles over in Gallatin County. Missoula also reported a couple of cases potentially they're monitoring due to someone traveling through and stopping who was known to be infected with measles. And so nothing here locally yet, but we'll continue to monitor through the end of the year to see if anybody from Yellowstone County happened to be over in Gallatin for the holiday. The FluView data system is back up and operational. And so you can see most of our country is seeing very minimal flu activity. We've seen a little bit of an uptick here locally. The Montana Respiratory Dashboard is live and is the best source of information. Primarily, you can see it's about 34 or 25 cases of COVID in Lewis and Clark, Gallatin, 24 here in Yellowstone. But influenza takes the cake with over 60 cases in Gallatin, 26 up in the Flathead. And so it is flu season, flu is here. So be as prepared as you can be. We're also seeing an uptick in pertussis locally. There were 13 cases of pertussis and 5 cases of chickenpox in our county this past calendar year. And so we're continuing to monitor patients that were seen in a therapy clinic here locally who were unvaccinated and had whooping cough. On the additional whooping cough front, Texas obviously reported the most at 3,500 and also had 2 deaths, while Louisiana and Washington are seeing an uptick of pertussis as well. There was a botulism outbreak late last month with 5 infant formula. We did not have any cases here in Montana, but just wanted folks to be as aware as possible. And my latest breaking news, I added late to the report yesterday, so it's not in your packet. I was appointed yesterday to the board of directors for AMPO, the Association of Montana Public Health Officials. So just wanted all of you to know that I'll be representing us on the state with AMPO. Couple reminders before I wrap up. Everybody's welcome, and we still need donations. We had a large community donor who was not able to donate this year to our holiday care package program. This is where we wrap gifts and provide Christmas presents for kids of clients that we serve within our clinic and public health services. And so everybody's welcome to join us for the gift wrapping party on December 12th from 10 a.m. to 2. So Friday the 12th, 10 to 2. Come help us wrap our presents. But if you're able and need a place to donate this holiday season, the foundation is taking cash donations so that Carrie and our Merry Band of Elves can go shopping for kids and patients in need this holiday season. So we'll gladly take any support there. And then
referrals of people that could donate. I think we had more people reach out to us than we needed. I think let's refer the people that didn't get smashed with families to you guys if that would be helpful.
That'd be great.
That'd be great.
Thank you.
Yeah, thank you. Yeah, appreciate that. So make sure everybody has a Merry Christmas. And then in January 20th at 6 p.m., just a reminder, save the date for our board dinner, our annual joint boards dinner with the clinic board, the Board of Health, our MFMR board members. All are invited. January 20th, 6 p.m. We'll have a great dinner, and we will be providing not only an annual review of things in RiverStone, but Narcan training as well. Questions?
Questions for you. Do we know how well the school district is doing in getting their must-have kids?
Their must-have kit.
The ones about the medical supplies they need.
So we know that SD2 is in pretty good shape. But we know that our rural schools need some more support. So we're working with our rural schools. I've been working directly with the Catholic system and others to make sure that they have what they need.
And then the second question was, if Kennedy and Company weaken immunization recommendations, do we have any plans?
We'll see what they do. It's going to be an interesting day. For those who don't know what Coach is talking about, ACIP, the vaccine recommendation board out of the CDC is meeting currently and talking about all sorts of childhood vaccine schedule changes, etc. So we'll see what happens.
Other questions for John? Hearing none. Dr. Littlefield, welcome back.
Thank you. Hi, I'm Megan Littlefield. I'm the Chief Medical Officer here in a position in the clinic. So my report is in the packet. I think John touched on most of the things. I gave sort of an update on recruitment, as we know, and as we'll hear more in our financial report. We're continuing to work on increasing encounters, and largely that impact has been related to staffing. So we have been continuing to really work on staffing. Part of that has been really work. So we hope, the medical assistants have been one of our rate limiting factors to getting providers in clinic. We actually, knock on wood, are at a point right now where we're still recruiting for a few providers, but we have more providers than we are able to staff because of our shortage in support staff. But we are hoping to remedy that And we'll be getting up by the end of this month to be able to get more providers in clinic, which is good for everything, including, most importantly, access. So, kind of along that lines, I talked a little bit about our workforce development. So, we know we've had the residency here. We've had the longest standing residency in the state. We are in recruitment season right now, which we're excited about. We are actually recruiting for our rural program as well in this cycle. So we'll be recruiting 2 more residents who will split their time here initially and then up in Miles City as part of a rural track program that we're starting. We also are really looking at how we can expand our onboarding of new behavioral health providers. So behavioral health providers get trained and get their masters, but then they have, it's not called a residency, it's called a candidacy, where they have to be in supervised training for 3,000 hours before they can be an independent provider. And so we are trying to increase our number of candidates that we're able to take on and train here.
Is that for workforce in general or specific to RiverStone Health?
Workforce in general. Yeah. So, certainly the residency, we know that over the last, 30 years, 60% of our residents have stayed either in Montana or in rural areas. We actually do. It's good for us too. We do recruit, we recruit our own and build our own. So a number of our faculty are residents who, were former residents here. But it really is looking at how do we improve the workforce, in our area. If you look at the number of physicians in Billings that were graduates of our program, primary care, family physicians, there's a.
And 3,000 hours, does that equate to 1.5 years or 2 years or 1 year or?
I don't know, 3,000, how many work hours are there? In
2,000.
Yeah.
28.
So it depends, and it depends how they do it. For the behavioral health providers, it depends how they do it. So some behavioral health providers will come, like the providers that we have recruited here, they're going to be here working as counselors. So 40 hours a week, however many hours a week they're seeing patients, we will be supervising them and providing them with those hours. Some people can't find jobs where someone's going to supervise them 40 hours a week. So they work, as a social worker, for example, for 40 hours a week. And then they work with a private counselor, someone who's willing to supervise them. And so for those providers, they're not able to do it as quickly. It has to be spread out over 2 years, is I think the rule that they have with their board, their governing board body. So that's for behavioral health. We also are looking at starting an APP residency, which we've talked about here. So that's a residency for physician assistants and nurse practitioners. They graduate from school and technically don't have to have a residency, but we know that, especially if you're working in more rural areas, having years of direct experience of having someone supervise you are critical. And so we have traditionally taken on new grads here out of the PA programs or NP programs because we're able to support them so well because of our family medicine residency program. We actually are going to put more structure around that, no longer hire new grads unless they're coming into our residency program, and really kind of formalize that program this year. Our goal this year is to take on 2 new grads. It's going to be a 1-year commitment. And then if we have space, they can stay. If we don't have space and they want to, they can stay. If we don't have space, then they can leave after that year. And we're hoping over the next 2 years to actually make that an accredited program. So we've been meeting with our current PAs and NPs as they're the ones that are largely going to be the faculty and helping to design that program so that it kind of comes alongside, but does not take away from our family medicine residency program. So that is really exciting that we're getting that off the ground. And then we're also looking at developing an MA training program. And part of that has come out of our challenges with trying to find certified medical assistants who are qualified to function as highly functioning medical assistants in our clinic. And so, so we're looking at how can we actually, and there are very few medical assistant training programs that exist in this area. And they're really quite expensive. And, you know, so it's hard for medical assistants to do a program like that and to have to pay for the program. So we're looking at how we would be able to do that here. And again, largely, you know, initially we're focused on how do we get them trained up so that they can stay here and really stabilize our workforce, but ultimately with the goal of how do we create a program where we can have people potentially graduate and be able to go to other places. So that's sort of the big news with our workforce development. We talked about some of the things that we're doing for access. We're spending a lot of time right now working on our QI and our value-based contracts and really looking at how can we improve our population health, but also improve capture of codes that ultimately increase our revenue by having better coding and better recapture rate of some of those things. So we're working on that. The Child Advocacy Center. One thing that I didn't actually put in my report that we just sort of found out is that, so you probably remember we talked about how the AG's office last year, we had gotten, Montana got $3.5 million in state money from the Johnson & Johnson settlement. And at that time, the AG had said that that money was all going to go to child advocacy centers, and they distributed, we got a $10,000 check, which we used for buying our equipment for photograph documentation. We now, and then it kind of went on hold because, you know, the elections happened and it wasn't real clear where that money was going to go. We just learned that they're going to, the plan is to give another $10,000 to each of the child advocacy centers. So we should be getting another $10,000, and they're really looking at what they're going to do with the rest of that money and figuring out how they're going to disperse it. I think still with the intention to get it to child advocacy centers across.
How many CACs are there statewide?
How many what?
CACs, child advocacy centers.
Right now, I think there are 10 that are accredited in Montana, 9 or 10 that are accredited. We are the only accredited CAC largely for the eastern side of the state. There's another one that is close to getting accredited, but we're the only accredited one up here.
So the state is essentially sitting on this pot of money. I mean, if there's 10 centers and you only got $10,000, that's 100,000 out of 3.5 million.
Yeah.
If I do the math.
Yeah,
I want to make sure I understood that.
Yeah. And I mean, I think the reality is there is a lot that needs to be done with child abuse evaluation and support in our state. The child advocacy centers are one piece of it. One of the things that a number of us at the child advocacy centers are sort of starting to look at is how do we create a child abuse network? We don't have any child abuse trained pediatricians in the state, not a single one. And so you have all of these providers like myself who are trained providers who have gone on and done additional training, not a fellowship, but additional training to become an expert in that, in that field. Right now, we're sort of all over the state, and there's no consistent way to support the providers who are doing that work. And there's a huge burnout rate. And so what happened here, and the way I stepped into this role, was that we had a provider who was doing this for 10 years since the start of our CAC. She was getting every call from law enforcement, every call from CPS. She was getting every call from every provider in surrounding areas who are like, hey, I'm seeing this kid, they have these bruises. What do you think? Is this something I should be concerned about? And not surprising, she got burnt out. And so we were in danger of losing our accreditation here because we need to have that medical piece. I tried to find someone who could step into that role, talk to Billings Clinic, we talked to Intermountain, we talked to all the providers in this area. We couldn't get anyone to do it. I had already been doing a lot of work with I run the foster care clinic here. So I do a lot of work that's adjacent to that. So I decided that I was going to do that temporarily because, I wear a lot of hats, temporarily until we figured out a way to build a system. And so that's part of the background work that I'm working on is how do we build a sustainable system across the state? Some of that AG money could be really helpful in doing that. So I think it's more than just the CACs. That's my little, soapbox talk about child abuse. So there's more to come there. I think we have a lot of work to do in the prevention side and in the evaluation and treatment side. Everything else is, if there are any other questions, I'm not going to touch on I'm happy to address the pertussis, measles, or any of the other, medical things if we have questions. Other than that, that's what I have.
Any questions for Megan?
Megan, how expensive is it to set up the training program for the medical assistants?
We have not actually fully outlined the financial plan for that yet. That's part of what we're doing right now. It kind of depends on how we structure it. And so what we're looking at doing is there are some online certification programs that you can do. So what we're looking at doing is what would it cost for us to hire people on, really do the hands-on training here. We have our simulation lab. We have, Dustin, who runs a lot of our training, is very skilled at developing hands-on curriculum. And so we're looking at how can we take that and bring that alongside an online certification program. So at the end of the year, we built a curriculum that they can do some online stuff, some hands-on stuff, some practical stuff in the clinic, and then be able to take the test and become certified. So we're still working on what that would look like.
What does it cost them if they do it? There are training programs. What are the
I
costs?
think, what was it we were looking, it was like $20,000.
So right now, the only local
Yeah.
one is done through the school district to
There's
like
that, yeah.
adult education program. And I think that one, I don't want to misquote, it's less than 10,000.
Yeah.
But the private schools, it costs 20 or 30
20,000.
grand.
Right. So there was Charter. So
Yeah.
Charter was a private program that was here. We actually have some graduates from that program, and that program, I don't think it's recruiting anymore. I think it's closed, but it was $20,000. Yeah. So quite expensive.
Well, if we could set up a program, give the students free tuition for a commitment to work for a few years for us.
Yes.
That's exactly what we're
Yeah.
looking at. Yep. That's exactly at structuring it.
And the other thing that we're looking at too is how can we play into the 406 jobs and apprenticeship program that's being developed at the state level. And I had a meeting with Commissioner Swanson and the Hospital Association last week. And that was what we talked about the whole time, was how do we, St. John's has a really successful nurse apprenticeship program that they are pumping nurses into our community from St. John's. How do we continue the success that we've had with MFMR and pumping physicians into the state for medical assistants, for nurse practitioners, for PAs, so we can build off some of these programs and find some additional funding streams to make them more sustainable.
Any other comments, Michael?
Quick comment, please. In both of these reports, there's a number of comments about a child advocacy program. I'm not sure there was in here today, the Kids Connect program. We talked about vaccines a little bit. It really is disturbing to me personally that there are so many of these programs. The Christmas wrapping for children in need. There's so many of these programs where children are at risk and in need. It's great that we're trying to do a lot to alleviate it as best we can. It's unfortunate there aren't more funds available. Why? That's a separate discussion. But I'm glad that we're doing so much to try to fill in the gaps for them. Just personal comment. Thank you.
Thanks, Mike.
Other comments or questions? Hearing none, Spencer and Shanna.
All right, well, maybe I'll start off by presenting our joint committee meeting, and then I'll turn the time over to and just go through the financials. But so we had two meetings since our last Board of Health meeting. The first meeting was a joint finance committee meeting with the Board of Health and then the RiverStone Health Clinic to review the audited financial reports, which currently still sit in draft form. Well, they're not in draft form.
They're done, yeah. We've received notice that the standards have been released, and so we'll actually get the finalized, hopefully today, get the finalized reports.
Okay. They'll be finalized today. So I think a couple of keynotes out of those financial reports, and also I wanted to just acknowledge Carolyn, Mark, and Jim for being in attendance at both of those meetings and setting time aside. So if any of you have any comments off of what I have, feel free. But there were no notable corrections or changes in the financial reports. So this is, and just as a reminder, our fiscal year runs from July 1st to June 30th. So these are the financial reports through June 30th, 2025. But there were no material corrections or changes to those financial reports or the reports that have been presented to the board, nor did they find any kind of non-compliance or material weakness in the way the financials are prepared. So I think that's a strong statement of support for our staff and for the effort that they put in. And then it's I believe the financial reports.
Spencer, do you know, has there ever been?
I think there have been.
I'm sorry, I didn't hear.
Have we ever had any issues uncovered?
Hi.
That
was the old people.
No,
throws every now and then throws an adjustment after closing out.
Yeah,
it's been the one thing. And I remember Shelley leaving something to be resolved at year end at some time in the last about 12, 15 years.
Yeah, very good.
Brett's older than me. He can go back far. I can't remember any significant material finding in any of these reports, but it always is nice to be able to offer kudos to the financial committee and staff for such good work. But
yeah,
I don't
in the
know.
1960s or 70s,
carry over vacation pay or something with statewide issue one time, but a long time ago. That was in the would have been the late 18th century.
kudos to Shanna and the staff.
We just won the war. That's right.
No, great job. So it isn't uncommon to have adjustments or things like that, but I think in our case, we've had a remarkable string of successful and unqualified. That's a remark. So with that, turns out we're Shannon.
it's good. Well, good morning, everyone. We've got quite a bit of financial information included in the packet. It's a September quarter end financials. And so we have the RiverStone financials, the Yellowstone Health Partnership financials, as well as the combined financial statements for September in the packet. I'll start off on the RiverStone Health side and just highlight a couple of things. Again, we do have the dashboards included in here, and so I want to continue to provide those just for a little bit more clarity and easy read of financial information. So I'll go through those in just a second, but just to comment on a couple of things on the RiverStone side. Cash total about $13.5 million at the end of September. That's an increase of about $4.5 million from where we were at September of last year. Of this balance, about $11 million is unrestricted. And if we look at our days cash on hand as it relates to that number, we're at about 69.17 days in September, which is an increase of 33.64 days from September of 2024. Really, through the government shutdown, our grant process and our grant draw process remained up to date. We didn't really have any issues with that, so that was wonderful for us. And then just a couple of things to point out on the statement of revenue and expenditures. We did receive our cost report settlement in the month of September that totaled about $153,000. This was our cost report for the FQHC. And we continue to be under budget in wages and benefits. We were under budget about $103,000 in September, and John spoke to the turnover ratios, but just to put it in perspective, FTEs totaled about 319 in September compared to a budget of 353 FTEs. So down about 34 from where we budgeted in September. For the month of September, our financials represent net revenue of about 462,000 compared to a budget of about 6,000. And if you're following along with the dashboard information, just a few things to point out on there. You'll see our days cash on hand up in the top left of 69.17 days. That is a little bit of an increase from where we were at in August. August, we were at 64 days. So continue to see that trend in the right direction. And then our days AR, we remain in a good place with that in the collection of our AR. We, like I said, with the government shutdown, we didn't have a ton of blips in the collection of our from both grants, contracts, and repair sources. So about 42 days in AR, if we look at that. Just a couple other things to point out as it relates to these dashboards. If you're looking at the variances and our net revenue over and under by service lines, you'll continue to see a pretty significant variance in 340B. We're at about a $76,000 variance to the good in the month of September for that, and about $147,000 year to date. So it continues to be a strong source for us. We have modeled all of the changes coming towards us, and with 340B starting in January, incorporated what we could into this year's budget. We'll just continue to manage and monitor and report on this as we see things coming. Any questions or comments on the RiverStone side?
Just curious, and the clinic services, the big budgeted decrease. If you just, what was, that's sort of, is that a one-time, what was budgeted in there that created such a substantial
Encounters.
change?
It's
I guess,
Encounters?
Yeah.
yeah, is it purely encounters that is?
Yeah, and Megan talked a lot about the MA shortage and those kinds of things. And so as we get that staffing back up, I mean, we'll see as we were looking through the October and November preliminary information, we're seeing it rebound based on those staffing levels.
Congratulations. I guess the other question, you had FTEs at 353 and this was at 310. I guess the question, if you were to look at it, and everybody would like to say, okay, it's 353, but what would you say between the clinic, health, and everything is 353 the number we're supposed to be at? Or I mean,
We actually just did this exercise.
no, thank you. I knew it. I would ask that question. I mean,
Do you know what off of our ideal, it's a
That was
lot.
just
Yeah.
clinic too, yeah.
So we did an exercise in clinic that said if we could staff to our ideal staffing ratio,
right.
so that we were bringing everything back online that we had to cut during, the Medicaid redetermination and COVID. It was substantially higher. So
384, since I don't quote me on that, but for some
Yeah.
reason I'm thinking it's
Yeah.
like 384.
it's almost 400 FT.
If you were, I'm just asking this question, or for ignorance, if you were to look at it and say, okay, we got it back to the 385, what impact on the revenue side would that have? I mean, would this is the way I would think, the return on investment for that personnel increase, would it be 1-to-1, 2-to-1, 3-to-1, 4-to-1? Any thoughts or any idea of what that might be? I mean, because when I look at here, when you look at just September's numbers,
Depends because there's support staff baked in there.
I understand. That's why I say, if you look at it and you say, okay, hey, we're going to 380, magically we can go to 380. That 380's got, is that producing some type of revenue, which I would assume it does, I don't know if it's a 1-to-1. So for every person I bring in and the dollars or whatever, I'm just more curious.
That exercise that John was referencing, really, we looked at a lot of that as it relates to clinic staff, right? Because there's
Right.
obviously revenue associated with a lot of those staff
Sure.
members. When we are adding those staff, we're not seeing a huge increase in that when we're looking at revenue. Part of it's based on our reimbursements. They're very set as we receive money back from Medicaid and Medicare. And when you start adding a bunch of providers in, that's obviously a high expense for the organization. So
Sure.
it really does depend on the positions that are being added into the organization. If they're grant funded, there's just a lot of little intricacies that go along with adding those FTEs. But as we looked at the perfect world and adding in all that staffing, really it doesn't end up being fruitful to the organization, just based on the numbers.
So I think the question becomes, following on Steve's deal, I mean, what benefit is it then if it's really not, I mean, it's at least, it should be, they should offset each other.
Yeah, and I think they would.
The
It's
cost should equal the benefits.
and serving more patients. I mean, there's a lot of good that comes to it too, but not. a
There's
huge
some
impact
value, I
on the
think,
bottom
in
line.
there. Obviously, I just, and once again, how I look at it, whether or not it's my hotel or Best Western, is I'm bringing on more people. Somehow I can't keep growing people without growing revenues. I guess that's the $62 question. And I was just trying to figure it out.
Even pre Forte, this organization has always run an efficient model of business.
Totally agree.
And the current government reimbursement model within our PPS structure for at least for Medicaid, it does not, you'd be surprised. The government does not reward efficiency. And so we're theoretically almost being penalized because we operate well, right? We're good stewards of our money. And so if we take a look at some other institutions across the state and elsewhere that are operating a little less efficiently than we are, they actually have a better reimbursement rate for Medicaid because of the cost of the care that they provide. And so we exist in this world where we're constantly battling what is the right cost of care per patient for us to get the best bang for our buck. And so Eric just sent me the gap numbers within the clinic, and we're currently at 156 staff in the clinic, and ideal staffing to bring everything else back online and operate the way we want to is 250, so almost 100 FTE.
Sure. That's a lot. That's a big number.
One, I know Megan's talked about this in her report, but value-based care
Yes.
is one of the things that's been introduced into the equation over the last few years, where it rewards providers for getting patients in for annual wellness visits. It rewards providers for having the patients get all their preventive measures. And if you don't have a system in place that works really well to help you get those patients in so that you can get rewarded, then you're leaving money on the table. So, and I know that it's been a little bit of a challenge at RiverStone to keep those people or to get them up to speed. And that's kind of like low hanging fruit in the equation.
I'm glad you brought that up, Carol, because we actually made some successful gains on that this year.
Good. That's good.
Across the state, our Medicare shared savings program with all 12 community health centers across the state, together, all of the community health centers in Montana generated about $3 million in shared savings this year. And so our dividend from that, because we were able to prove we had a 2% increase in our HCC score. I'm not going to get into that today, but it's a level of comprehensive care that we provide. We'll probably see about $200,000 back in value-based care payment because of that work.
But there's quite a bit more out there.
There is, yes.
Because you get paid for, if somebody comes in for an annual wellness visit, you get paid. But then you also get rewarded because there's just, I guess, what that equates to is looking where you have gaps in personnel and maybe filling the gaps where you could take advantage of some of those programs.
So you get rewarded and you get more money.
Yes, you get rewarded. Yeah, you get paid for the visit, and then you get rewarded if you meet certain metrics. Yeah.
So it's outcomes based. So if you have a chronic condition like a heart condition or diabetes, et cetera, and we keep you out of the hospital and we maintain balance in that chronic care, then the insurance company grants us some dollars for keeping you well and out of sick care.
And what I would say is that community health centers have been at the forefront of this work for decades because of the way our quality measures are reported. I think what is challenging for community health centers, including us, is we take care of some of the sickest population. So getting someone who is barely able to get food on their table, is struggling with mental health issues, maybe has an addiction, to realize that coming in and getting a mammogram is important, is really challenging, right? And so part of our work is needing to have care managers and other people on our staff who are maybe not generating when they talk to that patient, they're not able to bill for that service, but they're critical for being able to get those patients in and connected to those services. I think the other challenge that we've been having recently here, so what's happened over the past year is we've lost some of those support staff that are able to help with really trying to corral, some of those patients, and to help the providers do that work. But the other piece is a lot of it depends on how it's coded, right? So if you look at how sick our patients are from a coding standpoint, we actually don't look like we have a super sick population. That is not because we don't have a super sick population. We are relying on our physicians and our medical providers, in addition to all the stuff that they're doing, to remember to click on all of these boxes to capture these codes. That is not an efficient use of physician time. So when we talk about how we're trying to improve this population work, part of it is looking at who else on the care team, or how do we build our EMR in a way that we can capture these codes and get credit for the work that we're actually doing without asking our physicians to spend an extra 20 minutes making sure that they're clicking on the right boxes for, to capture that. And so it's complicated to get that revenue, because it's more than providing the care. It's getting the neediest people in for that care and then clicking the right boxes so that we should prove that we're doing it.
Well,
So
that's where all the clinical support comes in, and
Right.
they're the legs for doing that kind of enhanced documentation,
Right.
and expanded service delivery to be able to do parts of the equation, your visit volumes and your patient volumes, right? And the quality stuff is largely based on the patient volume, and then your visit revenue is based on your visit volumes. And so all that quality stuff is really where the clinical support functions come in to help be able to leverage those dollars.
An excellent conversation. We are a little bit behind, so I'd like to keep moving forward. I'm very empathetic to the billing discussions, having spent 30 years trying to address this stuff. But Shanna and Spencer, Coach?
Do we have to accept reports?
Yes, we do. I'm trying to get through the finance reports first. Rein it in.
Okay, just make a couple comments as it relates to the YHP financials, since we only take a look at those quarterly. One of the biggest things monitoring on the YHP financials, if you're looking at the dashboards, has to do with our days cash on hand. And this is a covenant that we have to report to as it relates to our bonds. It's a little bit different calculation than we're looking at on the RiverStone days cash on hand. It excludes some of the grant revenue and just has a few different intricacies to it. But we have to be at 60 days. That's our debt covenant. And at the end of September, we're at 138 days as we combine both the YHP and RiverStone entities. So that's a really strong thing for us. We're obviously projecting out with the purchase of the Colonial, what that could look like for us organizationally. And even with that, I suspect we'll end the year about 160 to 165 days in that combined cash on hand ratio for the entities.
Spencer, anything else? Shanna? All right, can I get a motion to accept the November 30 Joint Finance Committee notes?
Second.
All in favor?
Aye.
Opposed, same sign. Acceptance of the November 20 Finance Committee meeting notes.
So moved. Warlick. Second.
All in favor?
Aye.
Acceptance of the September 25 RiverStone financial statements.
So move. Second. Warlick.
All in favor? Acceptance of the YAP September 25 statements.
So move. Second.
All in favor?
Aye.
And acceptance of the September 25 combined RiverStone and YHP financial statements.
Or like, yes.
Second.
Second.
Spencer. All in favor?
Aye.
We're done with finance. Credits and debits are in balance.
Yeah.
Dr. Tapia.
There are two reports, one for November, one for December. Just to sort of clarify a little bit, we at the Safety and Quality Committee are in this cycle where we look at, for example, in this past quarter, we've looked at customer feedback on 1 month we looked at the clinic, the other month we looked at the Department of Health, and then this last month we looked at hospice and home health. Next, starting in January, we'll be looking at AI as it relates to each of these, and we'll do each month, we'll do the same sort of thing. Anyway, in November, we reviewed customer feedback for public health. And the challenge in public health is that the definition of customer is very broad. So we use a number of different ways of getting at that, including things like community advisory boards, the community needs assessment that was just recently done, steering committees, and that sort of thing. We give feedback back to staff via newsletters and staff meetings. And one of the things we learned is that every survey, every instrument that we use asks three basic questions. First is, was I treated with the dignity and respect? Second question is, staff was knowledgeable. And the third question, I am satisfied with the services that I have received. So those three questions on everything we do. They give a few examples. There's a thing called the HACCP, which we notice that we have lots of acronyms.
This job did not come with the BOA acronyms. So acronyms that we have as citizens don't. So I've come to Mark and Mike a couple times and they're like, no, that's not what that means.
Okay, so what that stands for is hazard analysis critical point. So we had a particular customer that had to have certain things done on his property, and things got bollocksed up, and it didn't go as well as it should. So that the sanitarian came up with a CT plan on how to fix that, and so they put the plan together. Then it still has to be reviewed and accepted, and that sort of thing. I'll move on. In December, we talked about customer feedback as it relates to hospice and home health. And here we have a national and local processes that get used. But on the national level, we have something called the CAHPS, which is Consumer Assessment of Healthcare Providers and Systems. And that's administered by a third party. The surveys get sent out after people have been discharged, and then that information gets fed back. Oftentimes it's 3 to 6 months old, so you question how valuable it really is, but that happens. We also have local, local volunteers that help us. Every Thursday morning, they come into the office here and they call and contact people who have either been recently discharged or discharged at some point in the past. And there's also feedback that's sought from the hospitals almost daily. Staff goes out and talks with hospitals and folks there. We also use our RL6 instant reports. And we have a number of examples of those. I don't think I'll go into detail, but the part of it is that there is a ton of assessment that gets done and feedback that gets reviewed and feedback that goes back to staff to make sure that catch all problems possible and that we improve our systems. Any questions?
Over the last 3 meetings, we've had overwhelming volume of data on customer satisfaction. I don't remember a single data point specifically, but I would summarize the last 3 hours in volume of data and say that customer satisfaction in general is extremely good.
Well, there's a lot of
all of the organizations. There are a few little points here and there where improvements can be made, but customer satisfaction is fabulous.
So that's my summary. Is it possible to show that on one of the dashboards similar to what we've done with financials? Is to incorporate that.
And there are dashboards that we looked at, but you know, we could probably do that.
Yeah. At a high level so people could look at it and say, okay, hey, this is what it is.
And you'll actually see some of that in Casey's marketing presentation too, on feedback and what we get on online interactions.
I guess the other question I would have, are there in this world, are there, my terminology is comp set. So, you know, it's like, okay, our comments are good, very good, but as it relates to our comp set, so whatever your comp set you consider, how do we rate in comparison to the comp set? Are we better, worse, or about the same? So we're measuring ourselves against ourselves, basically. But it'd be interesting to know, are we better, same, or worse?
Well, with respect to home health, there are, you know, that data that's collected is fed back, and we are in fact given scores and compared to, you know, statewide and nationally as well, on a number of different items. So yeah, there are standards.
So that would be interesting, I think, as well for us to see as a board. I mean, it's a barometer. I mean, I as a board member, I trust that what we're doing is the right, and we're doing the right things, and we're ahead. What I don't have is any data point to prove it in relationship to anything else.
If you weren't Michael.
I would assume he would.
The data are available and there are comparisons. And when those comparisons are done, I think, again, as a general statement, that's not to be trusted too much, but we are equal or significantly better than our comparators. There are occasional little dips, but they're minor. There's nothing that you look out and say, this is a mess.
We have the ability to compare ourselves to clinics, right? So we can do like to like in our clinic patient satisfaction. We can do like to like in our home health and hospice satisfaction. In fact, that's federally available. You can go to, you know, Medicare Compare.gov and see our star rating versus Compassus's versus, right? That's where we figured out last year, we were the first and only 5-star hospice program. Now we're one of 4 or 5 4-star hospice programs across the state. So they are comparing us to our competitors, and our clients and, you know, consumers are using those data points to make informed decisions about where they want to send their loved ones.
Well, I think it goes back, Coach, when we were talking about how do we, you know, when we were talking about dashboards and all of this for the board, this seems to be the answer to one of his questions is how do we create something, or is a dashboard that says how are we doing as it relates to our customer, I mean, our clients.
And some of those data are from national surveys. They're done for us. and some are homegrown. So it's a mixture. And whether there's a lot there. Also, if I could make a comment, so the next 3 meetings in this committee, we're gonna be looking at artificial intelligence. Not trying to be goofy. Maybe we can figure out how to use artificial intelligence to check all those boxes that need to be checked to get better revenue from. Let AI do check the boxes. They can listen to what what's going on in the clinic visits and look at all the notes.
We actually are.
Bob, you can get the word.
We actually are.
Yep, we do that already.
Yeah.
That's why we're improving.
It's.
We
it's not
don't
working.
compile all of the output we could from it, but we do use AI to listen to and record the conversations that go on during the patient visit.
Well, we will hear more about that.
Okay. Stay tuned, yep.
Anything else? Other comments or questions for Lance? Hearing none, can I get a motion to accept the November 25 meeting notes? Second?
Second.
All in favor? Aye. And a motion to accept the December 2nd meeting notes.
So move.
Second?
Second.
All in favor?
Aye.
Brett, what's going on in public health these days?
Well, our meetings typically start with the general policy update, dealing with litigation issues, but not John gives that presentation. So it's good for me to defer this portion of the meeting to John. For the presentation. Update.
What did I talk about? Goodness. So we, this was last month, it's not this month. But last month and this month provided some updates on the WIC and SNAP delays. At last month's meeting, we were talking about contingency planning due to extended government shutdown, and the fact that there was really no policy to talk about because everybody was home and on vacation out of Washington, D.C. But talked about how everybody in the community stepped up to support our WIC and SNAP clients and programs, and supported needs in the community with Family Service, who did, and STEP, who did the Billing Steps Up food drive to get resources out across the community. We did find, and we talked a little bit about the incinerator incident, and DEQ submitted their findings and final review of that incident to the city of Billings, and issued a violation notice for several findings of user error and violations related to how temperatures were maintained, how the incinerator was utilized, and the capacity of that incinerator. So they're working with the city of Billings to resolve that. There were no findings or any issues with the way we carried out our approval process, with the way we carried out our inspection process, and communicated with both the holder of the permit for the burning and communicated with DEQ. So we don't expect any other incident or issue with the incinerator issue at Animal Control. And then we continued our conversation about kratom regulation and how we can proceed there. As I mentioned earlier, next week we'll announce and share a press release as well as educational materials with licensed food establishments on the lack of safety around kratom containing foods and beverages. So that's all of that in a nutshell.
And at both meetings, we discussed the kratom situation. That's already been discussed. And, there'll be some enforcement starting soon, and we'll see if there's any pushback from that. The items, the public health needs assessment, which is when information gathering has been going on. There was a public meeting, I think November 21. I know John Doerr was there, the others were there, but gathering information, and the results are in the sense that we're seeing the same major issues: mental illness, substance abuse, And the final report will be out early in 26, and then we have a 3-year period to work on those activities, sort of an ongoing thing. The thing we discussed at the last meeting, which was kind of new, at least to me, and John already mentioned it, was the loss of the local outreach suicide survivor program, which you hear a lot about suicide prevention, but this program has to deal with suicide post-prevention, which I thought was a made-up word by the RiverStone Health, but it turned out to be 1972, some person came up with the term, and it specifically applies to support for persons after traumatic death and suicide. And a lot of suicides, I think, are related to earlier suicides. You know, in the case of a friend may trigger another suicide, a relative triggers suicide, and something sometimes we haven't thought about. And I had never thought about this before, but it sounds like a nice program where there'll be support and for persons who will be contacted who are close to a suicide death, the support provided. So.
Yeah, the other things we talked about at the last meeting that I didn't mention here yet. One was that we had just found out the new behavioral health facility is allegedly slated for Laurel. And we talked about all of the successful meetings we've had. We've been able to meet with our entire federal delegation this year and bring them on site, as well as majority of our local legislators in the House and Senate in Helena, and have them on site and meet with us. And then we'll close out the trifecta of elected leaders by having Governor Gianforte stop by later this afternoon for a visit with leadership. So good visits on the legislative front and policy front. We talked about the Board of Pharmacy. We talked about Kratom. We've been talking about 340Bs until we're blue in the face. And I got approval from our policy committee to sign on a federal letter to Majority Leader Thune, asking Congress to delay the implementation of the federal 340B pilot rebate program. And so we signed on to that letter, which was due to yesterday, to be sent to Congress, asking them to think again about implementing the 340B changes. We reviewed the Montana's application for an 1115 waiver for implementing new Medicaid requirements, and what those, we've talked about that here prior. And then we talked about the Rural Health Transformation Program, and the funding decision is pending from the feds. Although we will see, just like we've seen this week, the federal administration is withholding future SNAP payments from blue states. It would appear that they will withhold rural health transformation funds from similar states, which gives Montana quote unquote most favored nation status. And we should see additional rural health transformation program funding into our state to help us. So a couple of emphasis areas in which we're already working are school-based health centers, integrated behavioral health, rural health, and community paramedicine, where we have EMS providers bringing less ill patients directly to primary care office or an urgent care office in the community versus bringing them to an emergency room and utilizing better resources.
Any questions for Brent, John, or staff? Hearing none, can I get a motion to accept the November meeting notes?
So
Second.
All in favor? Aye. Motion to accept the December 25 meeting notes.
So,
Second,
more like,
and thank you, all in favor.
aye.
In the interest of time, I'm not going to comment about governance committee. You've got the minutes. Any questions or comments about the minutes? I have a question for you before I get your nominations for officers. Can I get a motion to accept those meeting notes?
So move.
All in favor?
I'll second.
Thanks.
I'll second them and you can. Well,
We have nominations. We need nominations for 3 more board members to serve another term, another 3-year term. Can I get a motion to nominate Spencer, Michael, and myself?
So move.
Second. All in favor?
Aye. Now they're nominated. We appoint them at this meeting, so this last meeting here.
I think we appoint them at this meeting.
Yeah, I think so. So I move they be appointed.
Second. All in favor?
Aye.
Recommendation for the reappointment of the foundation board liaison. Carol.
I'll move to reappoint myself.
Can I do that?
All in favor?
I second.
Aye.
All right. I reminded you this morning, last night, sometime, the opportunity to serve as an officer for this board. Are there any nominations for chair, vice chair, or secretary? Hearing none, the governance committee has recommended that we keep the same officers in place, myself, Steve, and Spencer. Can I get a motion?
I move we appoint those persons for their
Second.
respective terms.
All in favor?
Aye.
Governance is done. John, is there any old business? I hope not.
Don't believe there is.
Good. Home care and hospital, almost got it. I need an AI function up here to keep this on track. Is anyone here to talk to us about home care and hospice? Or am I supposed to?
So I'm Rochelle Prevo. I am with Health Case Manager. I took this position in September of 24. Due to our staffing limitations, I continued to have a patient caseload till about March. And then our senior director left in April. With those we've had some additional staffing changes. And we've been able to hire 1 full-time PT and 3 full-time nurses. We've implemented Trilogy Quality Assurance as an outside resource to improve our reimbursement and our quality. And we are in a rebuilding stage. So our focus is increasing our referrals through our collaboration with our community referral sources and engagement opportunities. Staff development is another key area we're going to address with the use of internal and external resources. And with all of our new team members, developing some team cohesiveness and communication so we can implement some strategies for improved scheduling and customer service so that we can grow our program and become a provider of choice for home health.
Who are your referral sources, the bulk of your referrals?
We get them actually in a number of areas. We have historically gotten more referrals hospital-wise from Billings Clinic, but that's starting to increase from Intermountain Health. We have increased our outreach. We do have a lot of outside referral sources also through just the outpatient clinics.
Okay. The outreach activities, are those directly to the hospitals or to other organizations?
So we have increased that. So we have always gone to the hospitals routinely throughout the week to touch base. What we've been able to improve though is have someone that's available to actually go visit those patients in the hospital now. That wasn't being done as well. So that's improved. And we have started, like yesterday, I went out and did a fall prevention class at one of the assisted livings. It was a great response. We had about 20 people, lots of questions. They were very engaged, all home health appropriate. So the goal is to have one of those a week where I can go out, or another leader in my department can go out and reach out to the community, find out what their needs are, and let them know that we're available to help.
Great.
I was very happy with the response yesterday. So I'm looking forward to doing more of this.
Is there more that y'all want to say about home care and hospice?
I can speak to our hospice side. I'm Anna Warburton and I am our clinical manager of our hospice team. Over the last year, our hospice team staffing position that has opened up throughout the year. Our census has been able to grow from an average daily census of 49 patients to 56 patients. This included the census from the hospice homes. We've been able to absorb those patients into the community and keep our census up. Our patient satisfaction scores are high and we are on track to be back to that 5-star rating with the next CMS publication. However, that publication date does not come out till August or November of 2026. But for the last several quarters, we have had that 5-star rating. We have been having a focus on our grief support, trying to revamp our Brave Hearts program and meet the needs of the community after COVID. People aren't coming in for as much group support and they want one-on-one. So we've been working on facilitator grief training, working with the help of Tamarack Grief Resource Center out of the western side of state. They have come in to help us work on all of that. We have redone all of our facility contracts with nursing facilities throughout Billings in the area, as well as both hospitals. And we have been able to successfully provide all levels of hospice care to the patients after the closing of the hospice home, including continuous care, providing one-on-one care with the nursing staff for these people who are passing at end of life. And we have been able to place 3 patients in facilities for their end of life stay who otherwise had no one to care for them, no one to safely give them medication, and no safe place to die at home. So
Where are those places?
we have worked with nursing home facilities and then used our hospice donation money to be paying the stay for those. So these people have no funding. They don't have time to get on Medicaid or anything else. And they are living in a hotel. We've had people living in their vehicles. And so we have been able to use our hospice donation money to put those people into a facility. We pay for their room and board then, and they are able to be medicated and safely taken care of it for their end of life. I'm just here for support. Good job. Thank you.
Wonderful. Any questions or comments for the hospice staff?
Question for home health.
Sure.
I mean, I'm sure it's a continuum of care from here to here, but what is the typical, when you say home health care, what does that mean for a patient or somebody? Is it like I go see them once a week, once a month? Explain to me home health a little bit more.
Sure.
I understand that going out and making the presentations, but that's got to be the smaller portion of what you're doing. The bigger portion has got to be the individual patients, I'm guessing.
Of course. That's a big question that is very confusing to a lot of people.
Oh, good. I'm glad I'm able.
Alone. So some of the confusion lies with the terminology. So we have been routinely labeled with home care. However, home care, if you Google that, is really caregiving. So someone who does for you. So say someone comes in and they dress you because you can't, they do it for you. Home health is a skilled service. And that's one of the things we have to do when we go in is set correct expectation, right? And that will help with our customer service. So if we go in and we tell them, and in their mind, they're thinking home care, then we need to make sure that we're setting the expectation, okay, this is what we're here to help you with. What are these goals that you want to work on? Whether it's, first, we're not going to use these words with patients, but disease management or wounds or you want to get your balance better, walk without your walker. So we identify those things. And then our goal in home health is teaching. So we're here to teach you how to reach those goals. One of the things that I think is confusing is we really need to empower them to learn so that when we walk out the door, they have the tools in place to be successful. So that's our goal. We are working on, those are some of the things that I'm trying to teach our team and collaborate on some things so that we all know what that looks like. What does coaching look like? And how do we, first of all, identify what the needs are, communicate that, find out whatever resources they need in the community, what equipment they need, what knowledge do they need to meet the needs to reach their goals. So it's really a focus on coaching and teaching. So we're short term. You know, we can go up to 60 days or more, but generally, you know, our focus is short term. So if there's any long-term needs, we're communicating with the provider or we're looking at vendors, other like caregiving resources. So if they need a home care service or if they need someone to help them with a Medicaid application. So looking at the patient as a whole, we do visits 2 to 3 times a week as a whole. And we can have any disciplines. We have nursing, PT, OT, speech. And then we have someone who helps with community resources. So we provide information and support in all of those areas. Like I said, it is short term. And then we just reassess, you know, we reassess, we use LPNs, RNs, PTs, PTAs, OTs. And as a team, we decide, you know, where are they at with these? So every week we have goals that we shoot for. And then we review and we say, where are we at? Are we looking at discharge? Do we need to extend? What do we need to reinforce with this discipline so we're all on the same page?
Great, thank you. Thank you very much.
Biggest difference?
That's probably more than you wanted.
No, great, you know, you say those words and I'm like, okay, I hear them, I understand what they mean.
This is the very first fight I had with our old brand guru was we're not a home care entity. We're a home health entity because we have licensed professionals, OT, PT, nurses that go into the patient's home and provide licensed clinical care. Home care entities provide non-licensed treatment. They provide companionship and caregiving and, you know, support with aides. We do the clinical care.
We do not have side, our title, just home care or home health.
Home health.
Well, at this house, there were some issues with the acronyms and so it was like,
Oh,
so it was like a home health, it was like RiverStone Home Health. And so we were labeled as home care. So we've recently transitioned to being home health, which I believe is really going to help us.
and I have a question. You say you're a shorter term. So longer term, then are they like referred to like a private service or something?
Yes.
Care.
Yep, or we're saying, hey, they need a higher level of care, and here's the resources out there. Or we will reach out to either the provider in the clinic if they have case managers that can help follow through more with that. So we help with, you know, are there financial restraints? You know, who can we identify to follow up? Because some of these issues are long-term problems, right? And they're going to be ongoing. So we make sure there's a connection in the community with their provider or another resource so that they get what they need.
And are those longer term services generally available? I mean, there's a shortage of that or?
There can be. Usually the constraint with those outside resources is finances.
Yeah.
Any other questions or comments about home care and hospice?
Home health.
Home health.
Home health. Oh, you learned. I love it.
I will tell you, you did a great explanation.
Oh,
For a non-medical person. You did. Everybody's around the table going, thanks, Steve, for asking.
That's good. Well done.
Marketing and communication.
There'll be some
Communication skills are waning.
home health and hospice in here too. So really, this is a look at what we've been doing from July on. I tried to sort of look at this fiscal year since our budget's starting in July. There's folks in retrospective, a little bit of what's coming forward. Really, from fiscal year 24-25, we're working with a marketing budget of about 100,000. This year we upped it to 130. Of that, 80 is actual ad spend. And we have big buckets for that. The biggest are clinic and hospice as our main revenue generating service lines. We also carved out a little bit extra for some WOW promotion, as you'll see here coming up. We really front loaded that starting in September and October to sort of kick that off in the fall as schools got rolling. And so to help with WOW, pharmacy again, give them a little bit of a boost as a revenue generating service line, and kind of highlighting them as really the only self-side pharmacy. And again, that flying horse retainer, we did send that out for RFP this spring. So they are still our agency. They help with design, placement, strategy, vendor management, not just for these ads, but for a lot of work outside in a lot of different design things that we need help with. So just kind of diving right in, and I'll try and talk fast because I know we're running short on time, Jim. I'll try and.
You're good. You're good. You go.
To start with clinic, I kind of put here on the top our tactics. Paid social is really just us paying to be put into people's social feeds. Google display really targets certain demographics. For clinic, we targeted adults 35 plus who are searching for healthcare topics. So when you search for that, our ad will pop up if you're Googling something. For clinic, our key messages from September through November, we're really trying to carry over some of the brand campaign we did from last year. Our overall mission, help, was a big one on that vertical one there on the left, really trying to say we are for everyone. This is the message that is everlasting in our marketing goals, trying to remind people that anyone can come here. And then really trying to span all ages, having imagery that's all generations, and then really trying to position us as the experts. These ads, we have results for these. They consistently do way better than the national average. So was there a question? I'm sorry, I can't. So our click-through rate, the national average is 0.2%, which doesn't sound like a lot, I know, but if you think of every time you see an ad, how often are you clicking on them? Our click-through rate was more than double that. And then out of those clicks, we were able to get 21 conversions that we actually called to click for an appointment out of those ads. Social also doing that, paid social also above the national click-through rate. So all told, we were getting about 10,000 clicks out of that. For November through January, this is the ad that you might see now. Again, paid social Google display. We switched up the messaging a little bit based on some feedback from our cross directors, trying to highlight our locations, give some more love to our rural clinics. So trying to say, hey, come see us at any of our clinics, trying to get the idea that it's not just here on the main Billings campus. Promote a few our telehealth, televisits, again, all ages, and a focus on prevention. Switching over to hospice, really we focused on Google display with this. So our target audience were, again, adults over 35, with the idea that it's not the actual hospice patient searching for this, it's their family members. Really people who are searching for health, retirement, long-term care, estate planning. And the focus on these was really caring for the caregivers. We really kind of honed in on this as the people making the decisions. We want them to know that they're the ones being supported and that we are the experts in this. And then again, just compassionate care is sort of always a message with our hospice campaigns. And this again was about double the national average for click-through rates, with about 26 conversions to like actually click the contact us button. So Also with hospice, starting December 1st, we have a banner ad running through the Gazette hospice page or Gazette obituary page. We chose this because the obituary page at the Gazette is one that is not paywalled, and that these months tend to see higher numbers of obituaries with the idea that more people are going there during December and January. So a little bit extra bang for our buck. Again, focusing on caregiver and expertise and compassion. So for print for home health and hospice, we did a little bit of unique leveraging of our limited budget where we're sort of splitting the back page ad, the cost of that between my clinic marketing budget and hospice's budget. So we were able to keep, with the increased ad rates, we were able to keep that back page of the Allies and Aging Prime Connections magazine. I really liked, not only is it a great partnership with Allies and Aging, I really like this product because it has all of the senior meal site menus in it. It is a product that tends to sit on people's side tables for the whole month. And so I think it's really valuable. In addition to the ad, we also get an article that really is themed health topics, usually done by home health, hospice, or clinic staff. So really highlighting the people behind the programs. And again, with a lot of the same themes. The one on the right there is our home health ad, really trying to emphasize the personal care and the individual goal setting. So those are the two big buckets. Any questions about those before I dive into WOW?
I'm curious on the one that you had that towards the beginning, you had telehealth.
Yeah.
I guess the question, the message, or the question is, has there been an increase in the number of telehealth, I guess, calls, or the amount of people that are requesting telehealth? I mean, can we draw any comparison between what's going on here and the numbers that are coming in through telehealth?
I'm not sure of that. I think there's just been a change in clinic in the telehealth platform, and I don't have those numbers, but I know that it's been increasing and that access has been easier. So I know we'll see an increase, whether it's based on the specific ad, I can't tell you.
I think Megan mentioned that in the report, that there's an increasing number of.
Yeah.
Right. So to me, because locations in telehealth, to me, are the two big.
Yeah. And then another clinic thing you're going to see a lot more of moving forward is our online scheduling. Really trying to remind people that's now an option.
Right.
And I think, and we've already seen a little bit of that I'll show you later.
Okay.
So Steve, you to the point, of course, the ads help, but the platforming was a big deal. It made it much easier, not just for our providers, but it made it much easier for our patients to be able to utilize it. Very simple ways to connect and participate in those telehealth sessions.
Yeah. I wish I could say it was all because of the ad, but.
Hey, say credit where credit is due.
I could try. So for our WOW, it's kind of a mini campaign. We only put 10,000 into this, but we really focused again on paid social, but also some geo-targeting. Really trying to target the areas around the schools that we were headed to with the WOW bus. Lewis and Clark, Skyview, Elder Grove, Creek, Riverside Middle School. And we're able to, if you have your location, this is the creepy part, if you have your location turned on your phone and you end up in one of those areas, next time you log into the internet, you may get pushed one of our ads based on where you were. So really trying to target the people that are in that area, that they can kind of know that WOW is coming to that school. Really, we're trying to push the all ages, that it's not just students and their parents that can come to WOW, it's everyone in the community that can come to this. So the for everyone, all ages, highlighting that it's community locations, and again, that we are the experts in this. So the other piece we did with WOW that is something that was a little new to me and I think went really well is we did a partnership with KGHL. John came and we did some interviews there with Taylor Brown. They really talked us up on air, but that was in partnership with a paid campaign that was ads on the radio that you'll see again in the spring. That was kind of a two-part where we did something. You'll see it, or you'll hear them again in the spring. Again, some of those same messages, just trying to get the word out around the launch, but then again in the fall. So, and those we did about 400 spots for a relatively small investment, and they've been a great partner for us. So really trying to reach out to that rural population. James Miller also did an interview kind of once the bus got up and running. James Miller, our PA main provider on the bus, did a great interview with them over the phone, talking about kind of how it's going. So.
And this one paid off too. The ag community has really listened and been interested in what we're doing with the WOW. And so we've been able to get out to the ag committee with the Chamber of Commerce. And then that led to us now getting a request from the MATE, the Montana Agriculture Expo, in February to have the WOW there and available for folks that are coming in to build relationships and trust with our rural communities. And then they've even asked me to present on a panel on rural health and wellness and outreach. So it's gained legs and momentum. And I think our farmer and ranching community is really interested in having access to healthcare.
Any other questions on WOW? For pharmacy, we really did some geo-targeting, and again, trying to leverage our physical location as a community pharmacy on the south side, really talking about convenience, that anyone can come here. It's not just for our patients, and that we're not just handing you meds, we're, you know, talking through drug interactions or any other questions you might have, really trying to connect people to a larger kind of our larger system of care. So our main targets on this were adults of over 25 in Yellowstone County. Our click-through rate did pretty well on the first campaign, which is the one on the right, above national average. We're able to see, because it's geolocated, after people saw the ad, we saw 379 visits of people who were on main campus after seeing the ad. So, you know, whether that translated into them getting a prescription is not quantifiable, but we were able to see that they were actually on our campus after seeing the ad, which is kind of cool. Again, the creepy part.
So is the RiverStone pharmacy a preferred pharmacy for most of the payer networks? Because, you know, a lot of payers steer you to a pharmacy that they want you to use. So is the RiverStone pharmacy in a preferred pharmacy and payer networks?
Some of them, not all of them.
Okay.
What about Medicare?
Well, Medicare, yeah.
Your prescription,
Yeah.
whatever, I guess it is, or whatever. All I know is that when I sign up, then the question I'm asked, you know, are you going to Walgreens, Osco, where are you going because of the prescription price?
Yeah.
And I've never thought of saying, oh, where does RiverStone? But I guess the question would be, where do they fall within that? So that would be another thing is to at least look at.
I think probably our bigger limitation in terms of pharmacy is that we're not credentialed as a specialty pharmacy. And so all of those drugs, so insurance products that require the use of specialty pharmacies for some of the higher cost biologics and stuff like that, we can't fill those. And so those all go out. So one of the things that Marcus, Shannon, and I have been talking about for upcoming, if we can ever get through all the craziness with just keeping up with the 340B changes, is looking at getting us credentialed as a specialty pharmacy so we can try and keep some of that stuff in-house.
So Walgreens and those are all considered specialty pharmacy?
No, that would be more stuff like, why am I blanking on the name?
Churros.
Yeah.
The specific drugs.
Yeah.
Food pharmacy.
Sorry.
Well, compounding, yeah,
Yeah.
stuff requires like more refrigeration.
Yeah, so a lot of like, a lot of like the hepatitis C treatment stuff, like a lot of the higher cost medications for chronic things like arthritis, diabetes, that a lot of insurance products require that you use their contracted specialty pharmacies. And not Osco. Why am I blanking? It's the one that we were just that
CVS?
Optum, yeah. Marcus was trying to get a contract with them and he's having a hard time. What's the name of it? I'm sorry, it's too early. Anyway, we that's more, I think, a limitation than like being a preferred pharmacy, because so much of our volume is Medicaid, and that concept really doesn't kind of transfer.
And you need space for it too. We'd have to have.
Yeah.
A footprint.
The minute I walk out of here, I'm gonna think of that stupid pharmacy name.
Okay. I saw I was running short, so I'll kind of breeze through these last few. Copies of this are in the packet, so you're welcome to look. But I wanted to show you the last couple pieces of the brand campaign that are the full page ads and Simply Local that are really more organizational based. Simply Local is also running WIC ads paid from the WIC budget. They have a special carve out for this that'll run through next September and probably continue on after that. We have our social media wrap up. Unsurprisingly, our top post was measles. I don't know if we'll ever reach this kind of engagement again. Normally our engagement is anywhere in the 1,000 or so views. So this one was pretty remarkable, but we continue to gain followers on Facebook and LinkedIn, and I'm hoping that moving forward, we can expand our social media platforms. Lots of events. We really, the only reason we didn't do more events is because of staffing capabilities and just having the staff to be there. So really, we're out there in the community. We're trying to be good partners and really just put ourselves out there. The WOW has been able to be there. You see in the background of our community breakfast photo there. So really having WOW it's a wow factor when people show up. We also do a partner newsletter that's some of you may be on that highlights our different programs. Earned media continues as our budget shrank over the last couple of fiscal years. We've really increased our earned media. Year over year, we're at about the same with 43 press releases and 89. It's been updated. There were a few more that popped in, so it's now at 89 media mentions between our weekly Health Matters column in the Gazette and then any other earned media. A little bit of here's how our website is doing that blip. You see in the middle there, that was actually the paid search results from hospice. So when we launched our hospice ads, we saw it in the blip, and you see that hospice spike there when they popped up. So our website continues to be really great, and we continue to update it and keep everything fresh on there. And it's really fun to be able to see the results of the ads in my Google Analytics reports. More on the website, you'll see I talked earlier about the online scheduling. I launched a new page, riverstonehealth.org/appointments. So as we build out different service line online scheduling, I'm able to add that into that page. Since the launch of the page, you can see we started with same-day care. We've now rolled out to main clinic. Tomorrow we'll add the rural clinics. You can see just in September, this is September through through November, already 1,000 views. Really, that's what people are looking for. And it was kind of an immediate hit. So moving forward in clinic marketing, you'll see a lot more online scheduling, and I think you'll see it get even higher. So that was kind of cool. Google ratings, this one's a little bit tricky. The clinic changed their patient review platform. So it used to redirect people to Google at the end of the internal survey. It no longer does that. Our Google reviews show that these are number of new reviews in 2025. So not overall numbers. So really, we are not getting a ton of Google reviews.
So the numbers are pretty much the same, but the low numbers also means that one-star review can make a huge difference. With every review, if it's 5-star, I pass it on to the program directors and any named staff, just as like a kudos. 1-star reviews, I'll respond on the platform and then pass it on to clinic leadership so they can address it. So, and then just to go out, there's a great review for dental. That staff consistently gets wonderful reviews on Google for their compassion and just overall level of care. So I love sharing those. So that's your good news to go out on.
Except that it says painless. They didn't have much done.
I guess it depends on the procedure. I don't know. My cleanings are usually pretty painless.
And speaking of going out on a high note, I want to take a moment and please help me recognize, give her a round of applause. This is Casey Page's last presentation of the Board of Health, as her last day is tomorrow. She's going home to Washington State and get closer to family and work for a critical access hospital in Moses Lake, Washington. So thank you.
Well, this is a special place and I have learned so much while I was here. And clearly it's stuck because I'm staying in healthcare.
Nonprofit.
Yes, nonprofit. Most importantly.
Apologize for letting this meeting run over by 2 minutes. Governance Committee will convene in 10 minutes. We are adjourned.